Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and turn in the program evaluations, and if you could give us any ideas in regards to future topics or future speakers, we would be appreciative. Reminder, no Grand Rounds next week or the week thereafter, so we'll reconvene in 3 weeks. Today, it's my pleasure to introduce Dr. Edward Clemmons. Dr. Clemmons is the most recent addition to the departments of neurology at McFarland and Mary Greeley. He did his residency at the University of Iowa and did an additional year of training in sleep medicine, and he's kindly accepted our invitation today to provide us with an update on obstructive sleep apnea. Please join me in welcoming Dr. Clemmons.
Thanks. Thank you. Sounds like everybody can hear me. Okay. So as he said, I'm Dr. Clemmons. I just joined up August 1st. Started seeing patients in the clinic August 15th. So been doing it for a couple months now. A little bit about me. I was born in Illinois, Champaign, Illinois. I moved to Ohio, Michigan. I lived all across the Midwest when I was a kid. But I've lived in Iowa now for 20 years. I went to high school in Western Iowa. As he said, I went to University of Iowa for my residency, but also for my undergrad. I went to Des Moines University for medical school. And right now I'm married to Teresa, is my wife, and she is a psychiatrist. She works for the Department of Corrections, doing out of their Fort Dodge Correctional Facility. And I have 2 little boys, one who turns 3 in December and one who's about 6 months old. That's Jack and Hank. So, all right. So, obstructive sleep apnea. I won't bore everybody who knows what obstructive sleep apnea is, but typically related to a disordered breathing due to narrowing of the airway during that impairs normal ventilation during your sleep. A lot of different areas that can end up with a collapse, which we'll kind of talk about a little bit here. Prevalence of OSA, it's highly variable from all the reports out there. About 26% of adults between the ages of 30 and 70 have obstructive sleep apnea. And the big increase we've seen recently is due to the nationwide epidemic of obesity. There's much higher prevalences noted in the populations of bariatric surgery and in our post-stroke patients, typically about 60 to 80%. There was actually a study done. It's not easy to do acute post-stroke patients and put them in studies on sleep apnea, but a study was done, I believe out of Harvard, that they applied auto-PAP to people, and if the auto-PAP increased in the post-stroke phase from the baseline of 4, they diagnosed those people with apnea. Now, we can get into the finer points of whether that's an accurate measurement of what sleep apnea is, but it does give some indication that there is an impairment in the airway and in the ventilation of these patients post-stroke. Obesity in and of itself is an independent predictor of at least mild OSA. Those numbers vary, but BMI greater than 30, anywhere between 30 to 50% chance that you have OSA just solely alone based on your weight. There's actually, Susan Redline did a study with the Wisconsin cohort that showed that an 10% increase in body weight predicted a 30% worsening of AHI, whereas a 10% decrease predicts a 25% improvement in AHI. But in no way, and we'll get to this when we talk about treatment, does that mean that your OSA goes away just solely by losing weight. If you're already obese, a 10% increase in your weight was equivalent to a 6-fold increase in having moderate to severe OSA. Additional features that are seen in most of our OSA patients compared to the general public include a large tongue and tonsils, a longer soft palate, the shallow airway seen with either a small chin or a retrognathia or a push-back chin, and large neck circumference, greater than 17 inches in males, greater than 16 inches in females is really the stats on that. And then comorbid diseases that herald increased rates of OSA include your heart failure patients, heart arrhythmias, people that have refractory hypertension, type 2 diabetes. There's actually a poster in my office that actually shows that obstructive apnea causes a lot of these things. So it kind of gets into this chicken or the egg phenomenon too, on whether, these people had OSA to begin with that led to some of these diagnoses, or vice versa. The consequences of untreated OSA are likely related to the fragmentation of the sleep pattern, causing cyclic hypoxia and hypercapnia, huge intrathoracic pressure swings, and increased sympathetic activity with frequent apneas. When I was a medical student, did a rotation with Dr. Peterson up in Cedar Rapids, who runs the Eastern Iowa Sleep Center. At that time, he was really focused on these comorbid diseases, and that a lot of the blood pressure and the heart issues that fall out of it are based on you're trying to breathe, your body wants you to breathe, your brainstem's telling you to breathe, and you're not breathing, and ultimately you shoot up in the night, wake up, I mean, not fully awake, but then that huge swing in pressure in the thoracic cavity and the huge increase in pressure from the heart is causing a lot of these problems that we're seeing, such as the high blood pressure. There's also the quality of life issues, decreased concentration, excessive daytime sleepiness, people falling asleep behind the wheel. My mentor at the University of Iowa always used to say, how many apneas does it actually take to cause a problem? And the answer is one. All you have to be doing is driving an 18-wheel rig and go to sleep behind the wheel, have an apnea, and crash that thing. There's also the separate bed phenomenon that I see a lot of in my clinic, that one of the bed partners has had to move out of the room because the snoring is so terrible, or they can't tolerate the person gasping in the night, things like that. And as we talked about, there's a lot of medical issues that fall out from OSA and also can lead to OSA. So in terms of screening our patients for the appropriateness of both diagnostic testing and treatment, we usually use a subjective patient questionnaire of some type. The two big ones that most people use are either the stop-bang questionnaire, where you're looking to get at least 3 points on it, or the Epworth Sleepiness Scale. There's been a lot of studies comparing them with the FOSS-Q, which the VA uses a lot in their research. There's been no study that shows that one is particularly superior to the other consistently. I personally use the Epworth Sleepiness Scale in my office. I feel like patients are able to better tell me, no, I'm not going to fall asleep in that situation, or there's a low, medium, or high chance. I mean, it's scored on a 0 to 3 scale, and it's 8 questions. So the most you can score on it's 24, the least you can score on it's 0, and they're in typical everyday situations. So sitting and reading, sitting and watching TV, not laying down on the couch and watching TV like you're going to fall asleep watching the Conan O'Brien show. That's not what we're talking about when I'm talking to patients. Sitting after lunch quietly, lying down to rest is an interesting question on it. That's actually supposed to be the de facto, is the patient kind of telling the truth question, because most people, when they lay down to rest, unless you are a true insomniac, are going to go to sleep pretty easily in the afternoon. And then the other ones are riding in a car as a passenger for an hour without a break, or driving the car sitting in traffic. If somebody's marking, they're driving a car sitting in traffic and they have a high chance of dozing off, not only does that patient need, screened, that person also needs to be instructed on, the safety concerns regarding that, and maybe they need to not be driving for the time being. There's been no correlation data that has been consistent between the screening scores and the severity of obstructive sleep apnea. I've had people tell me, "Doc, I'm not tired, my Epworth is 3, and they have AHIs of 75, 85 because they don't realize how tired they are. The same thing can be said actually for treatment of OSA. There is no correlation between severity of OSA and the amount of air pressure that's going to take to open the airway. I've seen plenty of patients who have, again, high HIs, and they need a pressure of 5 to keep the airway open and do well in the night. Symptoms that are approved for evaluation by most medical insurance companies for evaluation of OSA: non-restorative sleep, insomnia in its truest sense is a poor quality sleep, fatigue, excessive daytime sleepiness, either screened or reported. So even if their Epworth doesn't score out at greater than 10, if they say, "Doc, I'm tired all the time, I fall asleep all the time, I could sleep all through the afternoon," that counts as excessive daytime sleepiness. Witnessed apneas, snoring, uncontrolled high blood pressure, and then cognitive dysfunction, heart failure, those kind of things will almost always be able to get you a sleep study. I typically, when I write my orders, I write in, these are the 3 indications for it: snoring, insomnia, excessive daytime sleepiness, whatever I come up with in my clinic visit, and then also I include the BMI in there because that's a pretty big giveaway for them needing screened. All right. Our patient probably has OSA based on all this screening measures, so what should we do next? So when ordering the PSG, we do like you to try to include the indications for testing. Like I was saying, I try to put my 3 in there because it gives us an idea of why we're doing it, and then when I write the report or whoever's viewing it, there's some consistency between what's being reported by the patient and what we're reporting on the actual report. The sleep lab does provide an extensive questionnaire that asks a lot of these questions, and when I'm trying to come up with the indications for doing it, I'm usually leafing through this thing trying to figure out if they're saying they're sleepy or they're saying they're not rested in the morning, those kind of things. From a technique standpoint, there really is actually not much difference in ordering the routine sleep study and the split night sleep study. The techs overnight are going to be looking for a particular number. In this case, they're looking for an AHI greater than 30 that basically is indicative of needing to be split to a CPAP the same night. And that has to be done per guidelines after 2 hours of a diagnostic PSG. And you have to also have 3 hours available to do a CPAP titration. So even if you get to, say, 4 a.m. and now suddenly you have an AHI greater than 30 based on the overnight text count, you don't have enough time to titrate. So at that point, you'll just continue and complete the diagnostic exam. The only reason that I really ever write a split personally is if the patient has a previous diagnosis of OSA and they lost their CPAP for a variety of reasons, notably non-compliance. And usually then I'll say, previous diagnosis, please go ahead and split for an AHI greater than 20 once it's established. So it's a little more aggressive than the traditional split night numbers. That way they can get back on the therapy they actually need. So when the PSG is done, and now from our end, the overnight techs are scoring events on the fly, trying to make sure that we're efficiently managing these patients, looking for those indications for a split night study. As I mentioned, the daytime scoring tech then evaluates the whole study, looking for sleep-related breathing disorders, if there was any movements overnight, and does a full scoring of hypopneas, obstructive apneas, central apneas, and the limb movements. A hypopnea is 30% decrease in flow with a 4% desaturation of the SaO2. Apnea is a 90% decrease in flow for greater than 10 seconds in length. And that's done by looking at the pressure and the thermistor channels on our PSGs. Finally, then I get them on my desk. They bring them over about 2, 3 in the afternoon. Is that probably right? Yeah. And I start interpreting them then. I usually have them interpreted by the next morning. I look at the EKG, the limb movements, the breathing events, the EEG sleep patterns, and then I establish the diagnosis. So OSA is AHI greater than 5 with symptoms, with 3 signs or symptoms of poor sleep quality, or an AHI greater than 15 without symptoms. However, it's incredibly rare to end up in my sleep lab if you haven't complained of something to end up there. Severity-wise, I often don't mark this way. If you guys have been reading my reports or seen my reports, I often don't mark, this is mild, this is moderate. But mild apnea is greater than 5, less than 15. Moderate is 15 to 30, and then severe is over 30. Other findings you may see us mention in our reports, periodic limb movement index. This is one that often ends up in there. The PLM index needs to be greater than 15 to call it periodic limb movements asleep. There's been a lot of data that shows there's a 70% correlation between elevated PLMs and clinical restless leg syndromes. However, the opposite, if somebody complains of restless leg syndrome, there's only about 40% of those people end up with having PLMs on their diagnostic sleep study. So it's not a one-to-one correlation, clearly. And so what ends up in my report is I'll say, elevated PLMs. Oftentimes there's something called pseudo-PLMs or PLMs in the setting of untreated OSA. Oftentimes I won't talk about treatment or workup for restless legs in the original diagnostic report solely because these people tend to get better once you get them on adequate CPAP therapy. If they persist despite adequate CPAP therapy, then it warrants typically a workup. A workup that, if you want them seen by me, I'm more than happy to do in my sleep clinic. Otherwise, basic questions, the 4 questions are URGE, so urge. And the U is actually, do you have an uncomfortable sensation in your legs? It typically happens more at rest. Rest is the R. Getting up and going makes it better, so the G. And is it typically in the evening, the E? So URGE. So that's and if they have those signs, then that is clinical restless leg syndrome. Central apneas are sometimes mentioned. These are more often seen after we do a CPAP titration unless they have significant heart failure to begin with. So the central apneas have to have their own apnea index of greater than 5, and it has to be greater than half of the AHI to be diagnostic. So if a person comes in, they have OSA with an AHI of 45 for obstructive and 50 total, even though they had another 5 for central, we don't call that central apnea until their OSA is treated. Sleep-related hypoxemia, this is an SaO2 less than or equal to 88% for greater than 5 minutes of total sleep time once obstructions are treated. So we can actually qualify people for O2 if they continue to be are persistently below 88% for greater than 5 minutes and their apnea is treated in lab. Other findings we see from time to time, teeth grinding or bruxism, and then REM behavior disorder is quite an interesting one that we see in Parkinson's disease. These patients, the anterior horn cells and the communication there to make them have be atonic during REM has gone away, and it's seen with Parkinson's disease. So these patients, when they get into their dream sleep, are acting it out and punching the hat rack and jumping off the end of the bed. A pretty famous case at the University of Iowa was a person who thought somebody was breaking into the house, jumped off the bed, broke his face just because he was acting out a dream. And there's no amount of PAP therapy is going to treat that, but treating the Parkinson's disease can be helpful, and seeing that that's the case, then we can let the loved ones know about safety measures. All right, so he's been to the sleep lab. My patient definitely has OSA. Now what are we going to do? So PAP therapy is the gold standard for the treatment of OSA. Originally, CPAP, continuous positive airway pressure. One pressure value, you're breathing in, you're breathing out. It's the same pressure. Designed originally when they reversed a vacuum. That's exactly what it is. They switch the airflow and it acts as an air stent, basically to keep the airway open. It's indicated for all varieties, mild, moderate, severe OSA. The disadvantage is the patient who has significant variance in their positional needs. Typically, patients are worse when they're on their backs and also when they're in REM sleep. So we like to capture REM supine sleep when in the lab, especially during their PAP titration, because it gives us an idea that we're on really where we need to be on adequate therapy. Auto CPAP, so we've gotten a lot fancier. All the machines are getting smaller and they all look exactly the same. They just have a different card in them now and how they run. Auto CPAP is CPAP with a variable pressure head. So the min pressure is 4, the max pressure is 20. That's personally what I use beside my bed. My settings are from 8 to 15, in case anybody was wondering. But the advantage is it's good for at-home trials for those who just did not do well in the sleep lab, people with incredibly poor sleep efficiencies that don't sleep well anywhere other than at home. Patients who have varied needs based on their sleeping patterns. So if they do tend to sleep on their side, but magically end up on their backs. At various times, it allows for variable pressure settings. And it provides a lot of good data following an inadequate lab titration. So say we try to split them and we get to a point where they're still having obstructive apneas or obstructive hypopneas and they need more pressure. Usually in that situation, I'll bump them up one pressure point and then I'll run them on auto PAP. So say we get to, I just scored one today, we got to 9, they still had some obstructive hypopneas because now they were able to sleep on their back. I prescribed them auto PAP 10 to 20. I like to get data back from that in 2 to 4 weeks so that I can see what their pressure is. Patient I just saw yesterday, we were running him from 4 to 20, just doing a full auto PAP titration. His 90% pressure, the pressure he's at 90% of the time was 12.5. So every night when he put it on, going from 4 to 12.5, he was having continued apneas, continued hypopneas, and still his quality of sleep wasn't that great. So we adjusted that up yesterday. The disadvantages to PAP, to auto PAP, are that it doesn't change on a breath by breath. It sounds really good in theory, but it doesn't, it doesn't say, oh, you're blocked off, I'm going to increase you right now. It's these very proprietary algorithms in each of the makers' machines about how they decide to increase it. Typically adjusts over a variable time window. I like to tell people that it adjusts about over 20 minutes for one pressure point. So thinking of going from 4 to 12, 13, it's going to take some time. It's going to take 3 hours to get you there. Now you've had 3 hours of not quality sleep. That's why I go for the quick follow-up and to try to tailor the settings to make sure they're getting good benefit. Bilevel positive airway pressure, or BPAP. So a lot of people would call this BiPAP. BiPAP is actually a trade name. You'll see a lot of stuff that I put out as BPAP. 2 levels of pressure, an inspiratory pressure and expiratory pressure. Min pressure 4, max pressure 25. Your min pressure score is typically 2, and your max is 8 to 10, depending on your machine you're using. It improves patient comfort. The way I had this described to me by a pulmonologist at the U when I was there was it's a lung hysteresis effect. I don't know enough about the lung to be totally honest on if that's right or not, but basically the rusty door, so it takes a lot to get it open, but once you have it open, then you can just let it flow back and forth. And so the idea is that EPAP gets the door open. It's the CPAP variety. You got the door open, and now it's partially open, and the IPAP allows it to open the rest of the way. So when we make adjustments in the lab, we adjust the EPAP if we're seeing additional apneas, IPAP for hypopneas, and then you end up with this pressure support to basically keep that door open or keep the airway open in this case. The advantage, patient comfort. They're no longer breathing out against the same pressure in and out, and when you get to pressures of 15, 16, that's what people start to complain about. They start to complain about the pressure being too high, it being difficult to breathe out against, and those are the people that come back to my clinic and I say, okay, let's do a BPAP trial and see if we can't get you a better pressure setting so it's more comfortable. Typically improves your mask leak because of this, for the same reason the pressure is not as high. And then the other small factor is that it allows you to increase your pressure all the way up to 25, which max pressure for a CPAP is at 20. So if your CPAP has failed at 20, you can still get a little bit more pressure out of a BPAP. Disadvantages, requires that in-lab titration, lots of moving parts of figuring out apneas versus hypopneas, trying to figure out, are we moving both numbers at the same time, one number. It also worsens your central apneas. And typically patients will have had to have been seen back and failed CPAP in some way, usually complaining of pressure intolerance, or their machine kicks out data that says they still have a residual AHI or residual apneas. All right, auto BPAP. So now we're getting really fancy. BPAP with variable pressure heads. Typically I set this up with a variable EPAP, so an EPAP min, an IPAP max usually of 25 because that's what the machine maxes out at, and then a pressure support max and min as well, so usually from 2 to 8, or if we've already seen that they need to have at least a pressure support of 6, 6 to 8, so there's some variance there. It's used for the same reasons BPAP's used and for the same reasons that auto CPAP is used. So allows, again, for patients to have better settings if they have different positional needs, and also comfort from the CPAP being just too high of pressure to tolerate. Same problems, though, does not change on your breath-to-breath basis. They typically have to have quick follow-up, and it worsens your central apneas, and again, you have to confirm that they failed CPAP quite often. Or failed CPAP is not the right terminology. CPAP ineffectiveness is actually the medical legal jargon for it, is CPAP ineffectiveness. Other non-invasive ventilation. So this is a little bit different. These are machines that have backup rates that will trigger if the patient isn't breathing often enough. Adaptive servo ventilator, or an ASV machine. We use these a lot for treatment of emergent central apnea or central sleep apnea with Cheyne-Stokes breathing, seen in our heart failure patients. SERVE-HF was a study that came out, must be going on about a year ago at least, where it showed detriment in patients, increased mortality in patients with severe heart failure. And so a lot of sleep labs have gone away from using ASVs because of that finding. The one thing, the little loophole to that is if the original diagnosis was predominant OSA with central type events that wasn't resolved with CPAP and made worse with BPAP, we still are using the adaptive servo, and we're working on getting that up and going in the sleep lab here again. That and the next one on the list, the AVAPS, the average volume assured pressure support. So AVAPS is something that we used a lot at the university because we saw a lot of neuromuscular disease. So our Duchenne muscular dystrophy kids, we had a myotonic dystrophy clinic that had a lot of breathing problems. Then we also use it for obesity hypoventilation, and you can also use it for severe COPD, but there's a lot of hoops to jump through to get that approved. They have to have shown that they're well treated on a CPAP or a BPAP, and then had overnight oximetry that shows that they're still persistently low, and then they have to have a daytime ABG that shows that they're persistently hypercarbic as well. So that, to get all those hoops through, I mean, by that point, your patient probably needed ABAPs a while ago. Other therapies, these are some of the things we were talking about in terms of conservative type measures. Positional therapy, it's not really shown to have any consistent long-term benefit. We suggested a lot, especially for people that only have supine sleep apnea. The old tennis ball and a tube sock on a t-shirt thing. There's also these a lot fancier apparatus. You can get them on Amazon. You can get all these things to try to keep people off their backs. What we find is that if a person really wants to sleep on their back, they're going to find a way to do it. Whether they're just partially tipped over, whether they're fully on their back, they're going to find a way to be on their back, and they're going to have the same problems. Weight loss, as I mentioned earlier, it often improves your AHI, but it's rare to cure your obstructive sleep apnea. Very, very mild might be curable from just a little bit of weight loss, but not much other than that. Oftentimes, alcohol and anxiety medications tend to make your AHI worse, tend to lead to insomnia. Alcohol-induced insomnia is like, these patients are always waking up at the exact same time in the middle of the night, 2:30 in the morning, and then they can't go back to sleep the rest of the night. That is almost pathognomonic for somebody that has alcohol-induced insomnia. The respiratory depressants, the trade-off, or the anxiolytics, the trade-off there is oftentimes we use them temporarily to get people onto their CPAPs, onto their PAP therapy, and it tends to make them obviously worse. And so then the data that you're getting from the machine, are you getting the right kind of data back? We need to try to get these patients back off of these meds so that we make sure, once they get used to using their CPAP, so that they make sure to be getting full benefit and not having a hangover effect from the medications we're giving them to get started sleeping in the night. Surgical therapy, tonsillectomy, it still remains the treatment of choice in pediatrics, less than 12, assuming evidence of tonsillomegaly or tight oropharynx. No similar benefit in adults or teenagers, solely because by the time they get to teenagers, they're starting to look like smaller adults. and that's what the airway looks like too. Usually it opens up, the tonsils start to recede in size once they hit their teenage years, and so it opens up the airway. And so if they're having apnea, then they are really indicated for a PAP therapy. UP3, so the success rate of UP3 is only about 10 to 30% in terms of improving sleep apnea. My doctor didn't tell me that before I had one done. So I ended up with a UP3, but I still ended up with a CPAP beside my bed. So it's really good from a primary snoring, as it's usually excess tissue that causes the snoring. My girlfriend, then fiance, now wife, said, "You don't snore anymore. This is fantastic," but I still didn't feel any better when I woke up in the morning. It can be beneficial, though, if the obstructions are all happening at the palate level. If we can tell that that's the case, although there's no real good way of measuring that, but that's really the only way that it's been found to be highly beneficial, just because the highly variable levels of obstruction from tongue all the way to the windpipe, it's been being done a lot less. So this is one that a lot of patients are starting to talk about or coming in about. So oral appliance therapy, mandibular advancement device, mouth guard, a lot of names for it. The idea is that it pulls the mandible forward and opens up the airway. And so you can kind of even see in the picture, although I don't know if I'm going to get this. Oh, I can't get it. It really pulls the teeth almost in line rather than the natural overbite that most of us have, and again, it opens up that airway right there. It works really. It's approved for mild to moderate apnea. However, I have a lot of patients or have had a lot of patients in the past who have said, I bought this online and it doesn't seem to be working for me, and that's because they often need to be fitted by a dental professional, advanced by a dental professional, and then they should have a sleep study done afterwards to prove that it's effective. And so these patients aren't having that. They get something online, think that it's going to work for them, and then it doesn't. Common complaints with their therapies. PAP therapy, there's a lot of them. Air leaks, skin irritation, claustrophobia, tangled in my hose. It was too loud. I was eating air all night long and I feel bloated and belching in the morning. Dry mouth, pressure intolerance. A lot of these, and we'll get on to this, a lot of these I try to handle and work with the respiratory therapists at the DMEs, trying to make sure that we can get some of these things under better control. Surgically, recurrent snoring, reflux through the nose due to velopharyngeal insufficiency, or no improvement in their symptoms, and then the mandibular advancement device, tooth pain, jaw pain, because again, it really requires it to pull that jaw forward. The dentists that I've seen do them or worked with who have done them before, some of them actually have a different device that they have you wear in the morning while you're getting ready to kind of reset the normal physiology of the jaw while you're awake to try to prevent some of those TMJ type problems. All right, here we go. My patients are unable to tolerate their therapy. What are we going to do about it? Most of the PAP follow-ups I've asked to now see me to show benefit and compliance and meet their insurance standards. If you want to see your own patients, there's no problem. If you're sending them to me, that's fine. Just let me know if you want to see them instead. At that follow-up, we discuss their therapy as well as come up with any of those problems, try to come up with any of the fixes for those problems that we mentioned before. Even tangled in the hose, we have the ability to possibly make better. There's 200 or so different masks, nasal, full face, nasal pillows, where the hose comes in at. That's the one of the new ones has the hose come in on the top of the head, so there's no hose in front of you to get tangled up in. Nasal cushions, strap cushions. There's things that go around the mask to prevent the skin irritation. All these things can be really worked out in the clinical level. Additionally, in my clinic, when I see these patients and I get their data, I'll adjust their settings right there in clinic. If they're still having a high residual AHI, they're still having a lot of problems, empirically just giving them a couple more pressure points is simply something that's typically going to be well tolerated and also may benefit them. We discuss alternatives to PAP therapy. I mean, I see patients all the time that say, you know, doc, I saw X, Y, and Z on the TV, or I've heard about this. The one that we mostly talk about is the mandibular advancement device, or the oral device. It's definitely something that works for a certain group of people, but a lot of people it's just not appropriate for. Oftentimes, though, my CPAP compliance numbers are much higher in my patients who had severe OSA, mostly because they go, doc, I never knew I could sleep like this. And then also the ones that have had the alternatives and the diseases that can come from untreated sleep apnea discussed with them. I actually had a patient 2 days ago ask me if I would print off the poster that I have in my office so that he could take it home and keep it with his CPAP so that he would remember why he has to use this thing. So I printed it off. And then additionally, if the bed partner comes along and they think things are going better, it typically improves the compliance rate, especially if you can get them back in the same bedroom together. That tends to make everybody happier. All right, so what about the future? So have had a lot of questions when I was out meeting people in August, going around with COAN, discussing what our options are in terms of home sleep apnea testing specifically. Insurance companies have been moving to promote home sleep apnea testing as the alternative to PSG due to cost-cutting measures. Patients like the idea because they get to do it at home. But qualifying patients must have that high positive predictive value with the signs and symptoms in the screen that we try to get, you know, every time we're going to put somebody in the lab. But they can't have certain comorbidities. They can't have cardiopulmonary diseases. They can't have neuromuscular weakness. They shouldn't be on chronic opiates, or even symptoms of additional sleep disorders. If they say they have restless leg symptoms, they should be seen in a lab because of the PLM question. There's currently a division, though, about the best way to start home sleep apnea testing at most centers. The VAs have basically purchased equipment, and they sit down with patients, or have their nursing staff sit down with patients, teach them how to put it on, send it home with them. They have control of that machine. That machine has to come back. They interpret it. It's their machine. Lots of increased upfront costs to do that. In the private practice world, out in the rest of the world, a lot of them are hiring it out to DMEs or home sleep apnea testing companies, and you just have to send a single page in. It's a single page. You mark a few boxes, you put their name on it, you fax it to them, and they handle all the rest. You don't have to pre-approve it. You don't have to do any of the insurance work. They do all that. They send out the machine. They send it out with a DVD. They send it out with some written instructions, and they expect the patient to put it on with no guidance other than this DVD. As you might imagine, that gives you a significant variability in the technical adequacy of the studies, but increased efficiency for the providers, and no equipment to manage, no equipment to update, no equipment to calibrate. Devil's in the details, though. Home sleep apnea equipment costs are available to purchase, usually multiplied for your consumables, nasal cannulas, batteries, repairs, and then if a patient just walks off with it, if you've purchased it and it doesn't come back, now you're forced to try to replace that whole unit. Some patients, though, just don't have the technical acumen to understand the setup once they get home. If they do it 3 days later, they've forgotten what they were told in the clinic setting. There's no data to suggest which is the best home sleep apnea equipment. So there's some that are really cheap, there's some that are really expensive, there's a lot in the middle, and no one really knows which ones are the best to use. If you shop it out to a DME or a home sleep apnea testing provider, your studies are not usually going to be getting the same level of interpretation as you're going to get at the local sleep physician level, who would have the chance to review the EEG, review everything you see. You're just going to get this this resultant form that this is what they think this person has, and this is what they would recommend doing. The bigger problem, though, that we see is that if a study's not technically adequate, which, again, most of these patients that are being sent machines at home in a DVD are ending up with technically inadequate studies, the patient then is almost immediately sent for an in-lab PSG, and that's what the recommendation is on the bottom of the paper that you get back. Well, now you've multiplied the costs by doing the sleep apnea test at home and them still needing an in-lab study. Also, some home sleep apnea testing companies are allowing the local providers to interpret. I actually just emailed 2 companies this morning just to try to see about getting on their approved providers list for interpreting them so that we can start the process. I know I talked with the other Dr. Clemmons when I was out on the trail, and he was saying, you know, it'd be nice to get this up and going so that we can keep these patients in-house with us instead of having to send them out somewhere else that's doing it. And so I'm working on doing that. So hopefully that will pay off in the short-term future. The other thing that's coming in the future is cranial nerve stimulation. So there is a hypoglossal nerve stimulator, targets the muscle tone at the base of the tongue. It is a battery pack put in the chest wall, stimulation lead run up under the skin to the base of the tongue to the hypoglossal nerve, and then another lead run down to the diaphragm and to the intercostal muscles. It senses when you're trying to breathe, and what happens is it gently projects your tongue. So people aren't going all night long, but they are. If you see the video close up, the tongue just protrudes right up against the back of the teeth. And what it does is it opens up the airway in the same way that mandibular advancement does, in the same way that the CPAP does, by basically, in this case, activating the muscles that would typically be not activated when we're sleeping. ENT does it. They need to be trained in the implantation and the titration of the device. University of Iowa and Mayo are both doing it. Dr. Van Dale had just got started doing it at the university as I was finishing up fellowship over there. I just talked to the person that their rep they're using over there, and 3 patients are currently implanted with it in Iowa. So it is available. It is something to consider. The big issues that we run into with it are more the indications. So they want it to work, and so they're hand-picking the people that are probably going to do very well with it. So age greater than 22 years, not a big deal there. Moderate to severe OSA, so these are the worst of the worst type of patients. They're the ones that are going to feel the best once they get treatment. Unable to use CPAP for a variety of reasons, which are over there at the side. The AHI remains greater than 20 despite CPAP, which if your AHI remains greater than 20 despite CPAP use, something's not right about the pressure of your CPAP. You should not be that high. PAP intolerance with less than 5 nights of use per week, less than 4 hours per night of use, or just a straight unwillingness to use it also will get you a PAP intolerance as part of their inclusion criteria. ENT evaluation does not show complete concentric collapse of the palate. I'm not an ENT, obviously, but when I went to the AASM, the American Academy of Sleep Medicine, in Denver this past summer, the doctor that brought it, there's about 1,000 people in Europe that's already implanted, but the doctor who was one of the lead investigators here in the United States is at the University of Pittsburgh, and he had a lot of great videos showing the appropriate airways to use this on, and then BMI less than 32. So there's inherently the problem with this, right? So a lot of the BMIs we're talking about in our sleep apneics are 35, 36, 39, 42, and so they want people with severe OSA who are thin, and obviously those people are going to probably do better. That's it. So OSA in a nutshell. I think they're
Nice talk. I'm sorry I missed the first few minutes. Did you give us an indication of what overnight oximetry, home oximetry would have us pull the trigger for proceeding with a formal study?
What it would have to show?
Yeah.
So those home oximetry reports, they're going to report, sleep times below certain levels. Oftentimes, I don't know how many times it'll show your number of desaturations. I'd like to see if you're going to do that, your desaturations they should be at least 5, but even preferably 10 to 15 total desaturations a night with your lows falling below 88% really gives you a good indication that that person's probably struggling consistently throughout the night to breathe. But that higher number of desaturations alone gives you that flavor of the up and down that they're having, likely due to apneas or hypopneas.
All right, thank you.
Mm-hmm. Yeah. Yeah. Mm-hmm. I actually just talked to one of my friends in North Dakota who is a neurologist. He was actually just at the fall AAN conference, which I was jealous was held in Las Vegas. But he was saying that they did a sleep piece at the conference, and they reported that they're having a lot more problems getting things approved, like getting direct to lab approved. And I get that. I understand that. But we don't have a good way to do home sleep apnea testing and keep those people within our own little circle here. I don't think the overnight oximetry is nearly as good, but if that's able to get approved and you can see the data, that's going to be the step that is really necessary to even get past, hopefully, this home sleep apnea question and get them in the lab, say, they're hypoxic overnight, they're not they don't feel rested, and they're excessively sleepy. That should be enough in my world, and that should be my worldview of it, that should be enough to get them in the lab and get their testing. So there is utility to it. The question, I usually fall back on that if there's nothing else that I can get approved. Yeah. Yeah, and that's one thing that I found even on. I pay attention to who orders these, but I can't really tell you specifically who's ordering what. But I look and I say, okay, well, the indication on here is the patient fatigue is such a generalized symptom, right? So, patient complains of fatigue, and I go through their sleep charting. I go, I don't know how they were able to get this approved. Go whoever put this order in, but they don't complain of sleepiness, they don't complain of these things, they just complain of this fatigue. So it's incredibly variable, I feel like, on what you're going to get approved. And if you feel that way, then I say stick to your guns until you have no other recourse besides to say, all right, we'll get you a sleep test, or we'll try to get you a sleep test. But if it's not approved, it's not approved.
Yeah, thanks. Periodic limb movements, if you see that on the sleep study, the patient isn't bothered at all by it.
Yep.
The spouse is bothered by the kicking. I've been kind of resistant to treat those people. What's your feeling on that?
So I usually treat it, especially if the patient's complaining of persistent poor sleep problems. Now, that's usually the patient complaining of that. If the spouse is complaining of it, that's I guess a different battle, because a lot of the meds we're going to use to treat it are going to make people sleepier. They're sedating type medications, gabapentin, clonazepam. These are medications that we use for periodic limb movements, and so there's definitely some fallout from that they're could feel more, hungover for after sleep because these meds are on board. So I would probably not treat it unless it really becomes a significant problem for the patient.
Just a couple quick, what percentage, if you can isolate just snoring, what percentage of those people have OSA? And the other is, how significant are the cognitive effects, or how significant can the cognitive effects be?
The cognitive effects are important from a brain physiology standpoint. So one of the first areas affected by low oxygen and low blood flow to the brain is the hippocampus, which is what is responsible for encoding your new memories. So the other side of it, so there's a memory component of it that can be affected, but the other side of it is attention and concentration. So higher executive functions, executive planning, these kind of things. If you haven't had good oxygen flow to your brain doesn't feel like it's slept, it gets a lot, I mean, there's a lot of studies that show that people just can't think straight, for lack of a better term, but it's more of an attention, a concentration issue typically that we see with our sleep apnea patients. There is the memory component though, but so it depends on the cognitive complaint you would be talking about. In terms of the snoring, primary snoring without OSA, that's a good question. I honestly don't know off the top of my head. I want to say that those numbers are low, like 10% of people who snore that just primary snoring, nothing else associated, don't complain of, because there's people that we're not going to catch in the lab, right? They're going to have a sleep study. They probably have apnea. It's not a perfect test by any stretch of the imagination. That you'll actually, people who have seen my reports, I'll say sometimes at the end of them, because I get a flavor that they have apnea, I'll say, consider doing possibly a sleep-deprived study, because that allows people to sleep more on their backs and be more asleep. But frank, pure snoring, I can't think that prevalence is that high.
Hi. It was very interesting, the electrical stimulation at night.
Yeah.
For motor control. How about more oromotor exercises? Are those effective at all?
So there is a good study out of New Zealand or Australia about people playing the didgeridoo, and that's what it is for, is basically to tighten the oral muscles, and they showed improvement in mild apnea by playing the didgeridoo multiple times per day. So there is, yes, oral exercises in theory can probably help people with mild apnea. I think you reach a point probably that's not going to be as effective.
And I've seen, I think some of the, I don't know, Blue Cross plans have also, sometimes they do the sleep study and the patient comes back a month later that they got a $5,000 bill. I mean, is there a filter where, things can be checked at the sleep lab itself, or, somebody call insurance? Because the clinic, usually we don't call insurance company, because we put the diagnosis, whatever, hypersomnolence is usually a good diagnosis to attach for me, from what I've seen. But even then, sometimes they say, your insurance will approve only for a home sleep study first and not the lab sleep study, and I don't know, which plans go that road.
Yeah, and
then he gets a sleep study, and then they don't pay for it, and he gets a complete bill for that.
Yeah, so. and I don't know, Walmart's been pretty good about it, to be totally honest. I actually just had my first one since being here in 2 months and ordering multiple sleep studies, come back to me and say, we're not going to approve this. But one thing we haven't really done since I've started, and I think this is probably still me getting my feet wet to some extent, versus not wanting to change up too much too fast, is we haven't really changed like the order of operations when it comes to ordering these sleep studies on the primary care level. I don't know, I don't have a good answer for, how to get these things approved every time. I've always been pretty impressed with, or I was always impressed at the university. It seemed like we got very few denials, and so I don't know what they were telling them on the phone or what we were doing in our notes that was so great, but they had very few denials for these. And I really do think that there's something to that, the magic number of 3 symptoms. If you can produce 3 symptoms in a screening test that says it's positive, the only thing about it is now people are approving them, but saying home sleep testing instead of the in-lab. But that's how I've always approached a patient, is I'd like to see kind of the 3 symptoms before I'll say, you need a sleep study. They do, and that's one thing that I've actually changed in my clinic setting is I actually do the Epworth in my clinic because of if they're coming in, their primary complaint is a sleep-related complaint. They're getting an Epworth, they're getting a neck circumference because if I have a neck circumference greater than 17, I have an Epworth, and I have them complaining of crappy sleep. That's enough for me to really get home. So. Right, so Cheyne-Stokes breathing is seen with central apnea, not obstructive apnea, typically. If it's related directly to obstructive apnea, it's usually through the treatment side of things. So if it comes out, it's usually related to what's called treatment emergent, not emergent as an emergency. It means it emerges from treatment once we start using the CPAP, that they'll start having central sleep apnea with Cheyne-Stokes respirations. Typically, it's seen in our heart failure patients more so and not in obstructive patterning. Mm-hmm.